Okay, I think we are having some technical difficulties. I'm sure Alexander will join us again, but to save the time, I will start my presentation, the second one. So let me start with the second talk of this session. So today I'm going to briefly talk about anti-Mullerian hormone and its role as a diagnostic tool for PCOS. We already know that PCOS is a complex disorder with different phenotypes, and these phenotypes change through lifetime, even in the same individual. And since 2012, we now define 4 phenotypes of the syndrome. Phenotype A being the complete phenotype, having both androgen excess, oligoanovulation, and PCO morphology. Phenotype B missing the ultrasound appearance. Phenotype C is the ovulatory one, and phenotype D is the non-hyperandrogenic one. So when we look at AMH, that molecule is secreted from the small preantral and antral follicles, inhibits recruitment of primordial follicles, and it also inhibits the effect of FSH in the ovary. And recently, we also know that at the level of hypothalamus, the GnRH neurons also express AMH2 receptors, meaning that AMH is involved in the pathophysiology of PCOS. So this is data from Helen Mason's group. And if we look at the granulosa cell production of AMH, we see that it's increased in polycystic ovaries, and it's the highest in a woman with PCO and anovulation. And that's why it is proposed that the serum measurements of AMH could be used instead of doing ultrasonography and counting follicles and looking at the volume of the ovary. And as of today, we know that people are trying to use AMH at the clinic for different disorders, looking at whether AMH is high or low, and PCOS is one of the disorders whether AMH could be helpful for us. And this is recent data, including 187 non-obese women from a fertility clinic, suggesting that the AMH levels are associated with features of PCOS. So the higher the AMH levels, the more features of PCOS. But when it comes to use for diagnosis, you might have issues with the variation, and those variation could be related to biology, exposure, or technical lab. So starting with biology, we know that AMH decreases with age. So we need to pay attention to this. And if we look at BMI, this is again very recent data from US, an ancillary study, including 620 PCOS patients, showing that AMH is inversely correlated with BMI. So age and BMI are important for AMH measurements. And in fact, if we look at another recent study, we see that when we make the adjustment for age and BMI, when we measure AMH, it improves the detection rates of PCOS. But still, if you look at this figure, you see there's still significant overlap between women with PCOS and healthy women. Another variation would be measurement within the menstrual cycle. This slide clearly shows that at different age groups, we have a variation of AMH within a menstrual cycle. And in fact, AMH levels are higher during anovulatory cycles. And this slide shows us the variation between the menstrual cycles. So using different assays, we see here that there's a significant variation between the menstrual cycles within the same individual. So from biology, we might talk about exposure, environmental factors, and what is relevant for PCOS is the OC use. So this is a meta-analysis of 15 studies, including more than 3,200 women. If you are using OCs up to 6 months, there is no change in circulating AMH. But when you use the OCs for long term, then there's the decline of AMH, antral follicle count, and ovarian volume. But when you stop using OCs, there is recovery of AMH. Very recently, a few months ago, it was shown that even though OCs suppress AMH levels, lifestyle modification does not have that kind of effect. From that, we look at the variation due to lab. Here you see the different assays. Even though in the last few years, we have better assays, we have platform assays, particularly from Roche, Beckman Coulter, and Ansch Labs, there is still variation when it comes to measurement of AMH. And in fact, this recent study, including 848 patients recruited from an infertility clinic, comparing two platform assays, showing that there is more than 10% difference in measurement, and it is around 2.7 picomoles per liter on average. So assays are not comparable at the moment. And if you look at this recent international guidelines that we put up, the discussion was about polycystic ovaries, and you know well that even though we didn't change the volume cutoff to define PCOM, there is now increase in the number of antral follicles due to developments in technologies. So the cutoff now is 20. And with this cutoff and information, you see the relevant part of the guideline for AMH. Basically, we do not recommend use of AMH for the diagnosis, but we take it as promising for future. And in fact, this is one of the few evidence-based recommendations not to use AMH, even though the level of evidence is low. From that, based on recommendations from the international guideline, we have looked at the AMH levels in our prevalence study that included unselected women close to 400. And just to remind, the prevalence rates based on NIH, Rotterdam, and Androgen Access Society were 6%, almost 20, and 15% respectively. So we measured AMH on frozen serum liquids, and we used the Alexis Roche diagnostic. If we use the new PCOM criteria, what we observe is the prevalence of PCOS would be reduced by 50%, mainly due to decrease in numbers defined by Rotterdam and androgen excess and PCOS criteria. If we look at the adjusted area under the curve, by the way, all the data I'm showing you here are adjusted for age and BMI. That's what we need to do. So here we see the area under the curve for AMH under different diagnostic criteria. So even though with the new criteria, the area under the curve gets better, it's still low to use in clinical practice. And here you see the AMH concentrations depending on the phenotype. Phenotype A having the highest AMH concentrations. And here we see the area under the curve of AMH for the definition of different PCOS phenotypes. So for phenotype A, the sensitivity and specificity would be 65% and 92%, and the cutoff level would be 4.3 nanograms per ml. So that's fair to use, but unfortunately, if you look at this graph for other phenotypes, B, C, and D, we do not, the predictability is quite low. So we cannot use AMH to define these phenotypes. So it's only fair for phenotype A. And more importantly, if we look at the association of AMH and the features of the syndrome, you see the AMH is associated with age, BMI, waist-to-hip ratio, androgen excess parameters, both clinical and biochemical, but AMH is not associated with metabolic parameters that are available to us from this study in unselected women. So as far as I know, this is the only AMH study on unselected women. So we need more studies. So to conclude, AMH is involved in the development of PCOS. So we know it has a role in pathophysiology. Circulating levels reflect excessive accumulation of small antral follicles in the ovary. So maybe in the future, AMH measurement could replace ultrasonography in the diagnosis of PCOS. But this hormone shows significant variation due to biological or measurement-related factors. Very importantly, external calibration and standardized reporting is required. We do not have an international human standard at the point, so we are not able to compare different assays accurately. And finally, further research is needed on unselected populations to assess clustering of AMH with other features of PCOS, as well as to define the role of AMH to predict the future risk of PCOS and to see what would be the right diagnostic cutoffs. So thank you for your attention. So I opened up, finished my presentation, and I'm just looking at whether Alessandra was able to join us again. If she's not here,